Greetings, students. This is me, Dr. Tiwari, and today also I have come here with a very important topic, especially in psychiatry and in medicine. So this topic is very important. Almost obviously, every time one of the questions will be from these topics, and it's important as always for USMLE, PLAB, or NCLEX preparing students. So yes, as I always say, if you are feeling the speed of the presentation is slow, you can always fast forward in YouTube so that it becomes comprehensive as well as fast and entertaining. Look at this cat on the side. It's on substance abuse. It's on some substance. Okay, so now let's move ahead. So in this presentation, we'll be again talking about different substances, psychoactive substances like stimulants, hallucinogens, and about the depressants. We have already dealt with the depressants in previous video. So in this video only we'll be talking about the stimulants and hallucinogens. So we'll try to understand what are the different stimulants and hallucinogens, and at the same time we will try to understand their mechanism of action, their effects, as well as withdrawal effects, and also how do we manage each of them, and also some of the exam tips. So we have to understand what are their presentation is, so that we can make an accurate diagnosis and also a plan accordingly for the safe management of the patients. So psychoactive substances, they are classified, as I said earlier, as stimulants, depressants, and hallucinogens. So in this we'll be talking about this cocaine, amphetamine, methamphetamine, caffeine, and nicotine as stimulants, and hallucinogens. Under hallucinogens, yes, they are the compounds that alter perception and consciousness. So we'll talk about LSD, phencyclidine, that's PCP, MDMA, also called as ecstasy, and cannabis. One thing here, it's as a clinical pearl, I have highlighted that in acute presentation, recognizing the toxidome pattern is often more clinically relevant than identifying the specific substance, as management principle remains consistent within each class. That means it's often helpful in emergency setting to identify whether the substance the person has been taking, or whether the sign and symptoms matches with the stimulant class, or the depressant class, or the hallucinogen class, so that when we try to manage the cases, then it becomes helpful to us, because rather than the specific antidote, most of the time the supportive measures will be more specific to particular class of the substances. Now since we are talking about the stimulants, so let's talk about the stimulant. Okay, as I said, it's important to understand whether the substance the person is taking is a stimulant or hallucinogen or depressant. So since we are talking about the stimulant here, and there are different examples: methamphetamine, amphetamine, nicotine, cocaine. So we'd like to understand what is the holistic clinical features of these stimulants. Okay, so it's too easy. It's like a mood elevation, euphoria, increased talkativeness, decreased appetite leading to weight loss, insomnia, can't sleep, reduced sleep requirements, heart rate increases, tachycardia, cardiac arrhythmias, hypertension, increased cardiac output, okay, mydriasis, pupillary dilation, psychomotor agitation and restlessness, anxiety, panic attacks, and paranoia. And when this person, if they undergo withdrawal, then at the time they develop different features, like the features is like just the opposite of that. Okay, so the features will be like lethargy, psychomotor retardation, depression, dysphoria, increased sleep, so hypersomnia, increased appetite and weight gain, vivid and disturbing nightmares, anhedonia, inability to experience pleasure, and intense drug cravings. So it's like everything accelerates during use and decelerates during withdrawal. So it's just the opposite of what the usual effect of the drugs is, what we see during the withdrawal phase. So when the person is using these stimulants, everything is accelerated heart rate, so and when he or she quits the drugs, then at the time of withdrawal everything decelerates. So it's something easy to understand this. Okay, now amphetamines. Now we're moving to the drug specific under stimulants category. So amphetamine, the mechanism of amphetamine is that it induces a reversal of monoamine transmitters. So these include BMAT, dopamine transporter, serotonin transporter, norepinephrine transporter, and this reversal of monoamine transporters in the synaptic cleft, this leads to increased amount of these neurotransmitters, dopamine, serotonin, norepinephrine. These things increases in synaptic cleft, and because of that, the increase in the dopamine, norepinephrine, serotonin, this leads to stimulant action in the brain. So this is the mechanism of amphetamine. So again, clinical features as stated ahead. Amphetamine causes euphoria and feeling of grandiosity. Again, we said earlier, mydriasis. It also causes prolonged wakefulness and hyper alertness. The people become alert, super alert, and also hypertension, tachycardia, paranoia, psychotic symptoms, and hyperthermia and diaphoresis. Okay, now the complication, if the person is taking excessive amount, then at the time the severe intoxication may lead to cardiac arrest from arrhythmias or myocardial infarction. Similarly, generalized tonic-clonic seizures, hypothermic crisis, rhabdomyolysis, and acute kidney injury. And the treatment, we use benzodiazepines, either lorazepam, diazepam. So this helps to control the agitation, seizure control, cardiovascular stabilization, and also we provide support care with IV fluids and cooling measures for hypothermia and continuous cardiac monitoring. Now we'll move to the next drug. This is methamphetamine. It has a diagnostic triad of skin excoriation and severe dental caries. This dental caries is often because the patient will have bruxism and also dry mouth, so that leads to dental caries, and paranoid psychosis. So when the person, if you say to the substance abuser, if you say severe skin excoriation, severe dental caries, as well as paranoid psychosis, then we may think about methamphetamine use. Okay, and yes, so methmites, we call this also formication. So this methmite and formication is skin excoriation. So the person will be experiencing, when the person takes methamphetamine, he will be experiencing severe tactile hallucinations, like he feels like insect is crawling in his skin, so he'll try to gnaw their skin, and because of that severe scratching, picking. This leads to excoriation in the skin, open sores, scarring, and not just in the extremities but also on the face. So this we call it methmites. Okay, formication. And meth mouth, we said earlier, dental decay, dental caries because of dry mouth, or bruxism, that's teeth grinding, and also the person will not be having a proper oral hygiene, so this all leads to meth mouth, and that's again dental caries, tooth loss, and periodontal diseases. And as I said earlier, the person will be having paranoid psychosis and delusion of persecution, auditory hallucination, and extreme agitation. So these are some of the clinical features or clinical triads of methamphetamine use. Now we'll move to cocaine intoxication and complication. Cocaine, the mechanism is again similar. It blocks reuptake by dopamine transporter, serotonin transporter, and norepinephrine transporter. Just because of this, in the synaptic cleft there will be increased amount of dopamine, serotonin, and norepinephrine, and hence the serotonin stimulant action. So in cocaine, the patient will be having euphoria, increased energy, mydriasis, diaphoresis. Formication is also seen here. That's we call as cocaine box, and he or she has visual or auditory hallucinations, also paranoid ideation, and again myocardial infarction or sudden cardiac death risks. Okay, chronic use may lead to, in case of cocaine intoxication, chronic use may lead to, especially if the person is inhaling the cocaine, then it leads to ischemic necrosis of the nasal mucosa, and sometimes that leads to septal perforation, and we also call as saddle nose deformity. Okay, so if the person is in examinations, if the person is being demonstrated as having septal perforation, and most of the time it's because of cocaine, so you immediately think about cocaine. And again, mechanism is similar. We give benzodiazepines, and if you think about the chest pain and myocardial infarction, then you obviously start nitrates and aspirin. But also we will always avoid pure beta blockers. Okay, suppose in these cases there will be increased blood pressure, so the blood pressure in this case will avoid pure beta blockers, because as this is also important questions, because if we give pure beta blockers, then there will be unopposed alpha adrenergic stimulation that leads to severe vasoconstriction, and again that may lead to severe hypertension. So we have to understand this thing, that we will avoid pure beta blockers in case of cocaine intoxication. Okay, and caffeine and nicotine, these are common stimulants. Caffeine, its mechanism is like it is an adenosine receptor antagonist, and it indirectly increases catecholamine release, and thus leads to CNS stimulation. So caffeine is seen in coffee. We regularly use coffee. So the symptoms includes palpitation, tremor, gastrointestinal upset, anxiety, insomnia, and if the person withdraws and develops withdrawal symptoms from caffeine, then he may have severe headache. This is the most prominent symptom. Okay, sometimes this can serve as a hint that the person is developing caffeine withdrawal, and may have fatigue, lethargy, irritability, and poor concentration. So in this case, management include gradual tapering for heavy users. So if the person is taking let's say 10 or 12 cups of coffee regularly for a long period of time, and if he tries to quit and suddenly starts developing headache, then we may suggest him to gradually taper instead of abruptly stopping taking caffeine. And nicotine, it's again another common stimulant that the people take in terms of cigarettes. It stimulates central nicotinic acetylcholine receptors, and this leads to dopamine release, and yes, dopamine activates the reward pathway, so people becomes habituated to taking nicotine. So this is an example, or let's say mechanism of action of nicotine. And intoxication leads to increased alertness, so that's why people say that I like to do smoking because it increases my alertness. Okay, and yes, at the same time they will be having tachycardia, sometimes find tremors in their hands. And the withdrawal may lead to irritability, anxiety, increased appetite and weight gain, and poor concentration, okay, and the craving, of course. So the treatment for nicotine withdrawal is nicotinic replacement therapy, either in forms of pads, gum, or lozenges. And similarly, bupropion, that's norepinephrine dopamine reuptake inhibitors, we give this drug, or varenicline, so this is partial nicotinic receptor agonist. In examinations, I think varenicline, it causes vivid dreams. Okay, so this is one of the hint. This was one of the questions asked in USMLE, I guess, or in UWorld. Now next we'd like to go with is MDMA, that's ecstasy, the empathogen. Okay, the mechanism of action of MDMA or ecstasy is, okay, before talking about the mechanism of action of MDMA, the word empathogen, it means when the person will be taking MDMA or ecstasy, he feels emotional connection, he becomes much more emotional, feels empathy, feels warmth and connection with the people. Okay, so this, because of that, we call it empathogen. So now the mechanism is obviously it induces reversal of monoamine transporters with especially serotonin. Okay, especially serotonin, then dopamine and norepinephrine. So this leads to massive serotonin release in the synaptic cleft. Okay, so the clinical features is like euphoria, empathy, emotional openness, sensory enhancement, bruxism, that's jaw clenching, and mydriasis and increased thirst. So one thing we have to understand is that yes, MDMA causes is called as empathogen, which increases empathy or emotional connections between the persons, or emotional feeling in the person, but also it leads to increased thirst. So when the person is in the party, and if we or see let's say the youths, if they develop hyponatremia, then that's because of two causes. Okay, one is because of increased thirst, and because of that they will be taking excessive water, and the next is MDMA also causes SIADH. So the combined effect of both of these causes hyponatremia. And also along with hyponatremia there is hyperthermia, and always the risk of serotonin syndrome, because in MDMA or ecstasy there will be increased amount of serotonin. So if the person is taking let's say antidepressants like SSRI, then there is always risk of serotonin syndrome if he or she accidentally takes a MDMA or ecstasy during the dancing at the party in the evening. And similarly it may lead to cardiovascular collapse and hepatotoxicity. So the treatment for this is benzodiazepines for agitation and hypertonic saline for symptomatic hyponatremia if the person develops so. And active cooling may be necessary if the person has hypothermia, and fluid replacement if necessary. Similarly, yes, well, this is another important topic, hints. Okay, so if the person is developing severe hyponatremia, then he may develop severe cerebral edema, seizures, or sometimes even death may occur. And in that case, although we'll be giving sodium, but sodium must be given cautiously to avoid osmotic demyelination syndrome. So this is frequently asked questions in competitive examinations. Now we talked about MDMA, we talked about caffeine, nicotine, cocaine, and amphetamine and methamphetamines. Now after this we'd like to go to the next topic. Those are hallucinogens. So out of which we'll be talking about LSD first. Okay, so LSD is a classic hallucinogen. It causes alteration in perception, thought, and mood through serotonergic mechanisms. Okay, so in this picture, these are the common side effects of LSD: dramatic changes in sensation and feelings, altered sense of self, swinging rapidly from one emotion to another, altered sense of time, feeling several different emotions at once, and crossover senses. That's synesthesia. So as we're talking about LSD, so the mechanism of LSD is that it is a potent serotonin receptor agonist. It disrupts normal sensory processing and thalamocortical signaling, so ultimately producing altered perception without delirium. So this is important. Okay, the person who is consuming LSD, he will have altered perception because of excessive amount of serotonin that leading to excessive thalamocortical signaling, but at the same time he will not be having any delirium and will be oriented. Okay, he will just be having altered perception but no delirium and intact orientation. So the perceptual effects are like visual distortion, there will be geometric patterns, halos or trails that is seen by the patient. He or she will experience synesthesia, that is mixing of the senses, or let's say crossover of the senses. Will feel auditory changes, depersonalization, derealization, altered time perception with subjective time dilation. So these are some of the clinical features of LSD. So physical findings, you see hyperreflexia, again mydriasis, hypertension, tachycardia, that's common, but hyperreflexia is seen here, hypothermia, pyrexia, and yes, as I said earlier, the patient remains oriented despite perceptual distortion. And the complication it can lead to severe anxiety or panic attacks in case of acute intoxication, and which is managed with benzodiazepines, and a patient must be kept in calm environment and adequate reassurance must be given. Whereas if the person is taking LSD for quite a long time and is using it chronically, then at the time he may develop hallucinogen persisting perception disorder, in which he will develop persistent flashback weeks to months after use without re-exposure. So the person will be taking LSD for, let's say, 6 months, and then if all of a sudden he has stopped taking LSD, but still after 8th or 9th month he will develop hallucinogen persisting perception disorder. That means he'll have the flashback, okay, spontaneous flashbacks of everything, this visual distortion and everything, and that we call as hallucinogen persisting perception disorder. So that's another complication of taking LSD. Now we'll be talking about the cannabis, okay. And cannabis, marijuana, it's another common drugs. So here cannabis acts on the cannabinoid receptor. It's a cannabinoid receptor agonist, and yes, it modulates the neurotransmitter release and alternating neuronal excitability. So it's again causes neuronal excitability. It modulates neurotransmitter release and acts on cannabinoid receptor. So acute intoxication of cannabis leads to euphoria, relaxation, altered perception of time. So here she feels the time to be subjectively slowed. I mean, the time is passing by slowly. That's what he or she feels. Increased appetite, so, and impaired judgment and coordination, impairment of short-term memory, conjunctival injection, bloodshot eyes, the eyes will be red. So this is another important hint for diagnosing marijuana use, okay. And also dry mouth, because of that they take a lot of water, mild tachycardia, okay. And if he or she has taken very high dose, may develop anxiety, panic attack, paranoia, or visual hallucinations as well. The withdrawal syndrome of cannabis include irritability, mood instability, sleep disturbance, anxiety, decreased appetite, headaches, intense craving, okay. And the symptoms peak at 2 to 6 days, and gradually the withdrawal symptoms peak 2 to 6 days and gradually resolve after 1 or 2 weeks. So if the person has been taking marijuana for, let's say, years and years, and if he stops taking suddenly, then there's all these symptoms of sleep disturbances, headache, intense craving will be peaked up to first week, and after first week, or let's say after second week, this will eventually resolve. Management includes supportive care for acute intoxication, and always consider gradual taper for the one who has severe dependence with it. Now we'll like to talk about PCP. This is called as phencyclidine. It causes dissociative anesthesia, okay, anesthetic effect, okay. So pharmacology of PCP, it includes, yes, so the mechanism of action, or let's say the pharmacology of phencyclidine, that's PCP, is NMDA receptor antagonist. So it leads to dissociative anesthesia and separating perception from sensation. So yes, it was originally developed as an anesthetic, so hence it's called as dissociative anesthetic, okay, but discontinued due to severe psychiatric adverse effect. So some scientists started developing PCP for, let's say, anesthesia, but unfortunately because of this dissociative side effect, it had to be stopped. Now the toxicity is that if the person takes this, then he may develop paranoid delusion, delirium with disorientation. Remember, in previous one we said that there won't be any, remember we were talking somewhere here, okay, never mind, we'll go down here. So yes, as we're talking down here, where we yes, here, when we're talking about LSD, we said that the person orientation remains intact, only the altered perception, and there won't be any delirium, there won't be any disorientation. But here, when we talked about PCP, we said that the person will have problem, especially with regards to orientation, so that will be delirium is also present and disorientation is also present. Okay, so just a comparative talk. And then the person may develop generalized seizures, hypertensive crisis, rhabdomyolysis, and hyperthermia. Clinical features also, one of the most important hint in examination is that the person taking PCP will have particle nystagmus. Okay, particle, sometimes horizontal or rotatory too, but the particle is the key differentiation. So if the person is said to have particle nystagmus, then always remember PCP. This is highly specific finding. And also when the person is taking PCP, he or she may have violent or bizarre behavior, becomes impulsive, psychomotor agitation is quite high, tachycardia, hypertension, profound analgesia. So because of this, the person may do self-injury because he or she doesn't feel any pain, so will does a self-injury, and hyperthermia. So yes, based on the symptoms, phencyclidine is quite easy to diagnose. One, particle, especially particle, and next is severe or violent behavior, fighting, cutting, self harming because of profound analgesia. So these two are the quite differentiating features based on which we can easily diagnose the person is taking PCP. Management, we have to put the patient in quiet and low light environment so that there won't be much external stimulation for him, and benzodiazepines can be given for agitation. And if the benzodiazepine alone cannot calm the patient, then we can also add haloperidol or some other antipsychotics. It's suggested not to physically restrain these patients because of fear of rhabdomyolysis. Okay, and yes, as I said earlier, particle nystagmus in an agitated or violent patient with analgesia, always think about PCP intoxication. Okay, and yes, now we have talked much about the stimulants as well as the hallucinogens, and few clinical parts for examination is that we can always look for pupil size, skin finding, and vital signs. These things are important in distinguishing what the clinical features are and what the substance the person has been taking. Okay, and similarly, sometimes this is another important thing. Okay, sometimes it's difficult to differentiate between sympathomimetic or anticholinergic, like intoxication. So in sympathomimetic drugs, if the person is taking stimulants or which has sympathomimetic action, the person will develop diaphoresis, that means become sweaty. But if the person is on anticholinergic, okay, like atropine, then at that time there won't be any sweats. So this is whereas other symptoms like tachycardia, dilated pupils, agitation, they occur in both sympathomimetic as well as anticholinergic toxicity. But the only differentiating factor is that if the person has sweat, then that is sympathomimetic. If the person is not sweating, it's completely dry. Okay, and that we call is anticholinergic intoxication. Another clinical parts is that benzodiazepines are first line for agitation, seizures, and sympathomimetic toxicity. So this is also important. So if the person is taking in examination, if the person is taking cocaine, amphetamine, and has all the features, then I have to choose one drug. Then most of the time it's benzodiazepines because it helps to calm down the patient. Okay. Also, when the person will be taking stimulants, and if the person is suddenly stopped taking it, then he or she may develop withdrawal, and at that withdrawal, he or she may soon land up in depression and may have suicidal risks. Okay, so we will rather either do close monitoring and follow up, or better hospitalize the patient if the patient is under recent cessation of consumption of these sympathomimetic drugs. So this clonus and serotonin syndrome, we'll talk in different topics also. So for now, let's just read it out. Presence of clonus, spontaneous, inducible, or ocular clonus distinguishes serotonin syndrome from neuroleptic malignant syndrome, which presents with rigidity, not clonus, and all of the symptoms may be same. But if the person has clonus, that's serotonin syndrome. Clonus, like and if the person has rigidity, then we call this neuroleptic malignant syndrome. This is very high yield in examinations, but we'll talk this in later other videos also. Cortical nystagmus is always, as I said earlier, PCP. Sometimes if the person has horizontal nystagmus, then there may be other diagnosis also, but if the person has vertical nystagmus, then it's always PCP. And also in PCP, we also said that patient has agitation, fighting, impulsivity, and self-harm behavior also because of profound analgesic effect on the patient. Okay. Yes, now final examination strategy. It says that when approaching toxicology questions, follow the ABC first. You must always stabilize the patient first, then identify the toxidome using pupils, skin, vital sign, and some of these specific features like severe agitation or nystagmus for PCP. Yes, so based on this, we'll just try to identify the toxidome, and then we'll try to choose the management accordingly. Okay, and if available, we may use specific antidotes also. Okay, I think with this we cover this very important topic. I'm sure 1 or 2 questions will be from this topic, especially in USMLE examinations, either in step 1 or step 2 or step 3, also in PLAB and NCLEX examination. So this was very important topic. I suggest you after watching this video, if you want to rewatch this, always increase the speed of in YouTube, and after doing this, try to solve problems, and I'm sure you'll be able to solve maximum number of the questions. If you have any queries, please comment, and please don't forget to like, share, and subscribe, so that I will be inspired to create much more of these types of videos. And if you have any suggestions for the slides, always feel free to comment down, and I'll try to incorporate your feedback. Okay, see you in the next video. Bye bye.